6 past, Prof. Prof. Tati, I think we can start, yeah, Prof.
Yeah,
Okay.
please.
Okay.
Yeah. Please, Dr. Prasad.
Right. Good afternoon, everybody. My name is Prasad Abeysinghe. I'm moderating today's webinar, which is hosted by Sri Lanka College of Oncologists. Our speaker today is Dr. T V Ajithkumar, whom I will introduce later. But let us first start by welcome remarks and introduction by the FARO. It will be done by Professor Imjai Chitapanarux, President-elect of FARO.
Okay, Dr. Nico, please put up the pre-recorded video.
Dear colleagues and friends of FARO, on behalf of FARO Council officers, it is a great pleasure to invite you to the 19th FARO webinar with the theme Perioperative Stereotactic Ablative Radiotherapy for Pancreatic Cancers, which is organized by the SLCO, Sri Lanka College of Oncologists. Tonight, we have a distinguished speaker, Dr. Translational Ajithkumar from Cambridge University Hospital and HS Foundation Trust in UK, and also 3 panelists from Sri Lanka, Japan, and India. I thank to all of you for contributing this webinar, and I wish you all a very successful webinar. Thank you very much.
Muted, Prasad,
Sorry,
muted.
you're still on mute, Dr. Prasad.
Prasad, you are muted.
Sorry.
Unmute.
Thank you very much, Imjai. Next, I would like to invite the President of Sri Lanka College of Oncologists, Dr. Nadarajah Jeyakumaran, the President of Sri Lanka College of Oncologists. Please.
Greetings from Sri Lanka. I am very happy to note that once again, Sri Lanka College of Oncologists hosts this FARO webinar. Today, actually, it's the 19th FARO webinar on the topic Perioperative SABR for Pancreatic Cancer. Our speaker is Dr. T V Ajithkumar, who is a world-renowned clinical oncologist and editor-in-chief of Clinical Oncology Journal. I believe this sort of collaboration and engagement with enthusiasm among us to share the updated knowledge and skills in this region will help a lot because we as the academic bodies in the region of Asia has to continue to share our knowledge and continue to try and address our issues in an academic manner with the help of well-renowned faculty who are our expatriates in the West who can help, and we have to be in par with the Western Oncology Society, and we will get that sort of recognition, and we will look after ourselves in a better way, jointly with networking and collaboration. Thank you once again. Thanks.
Thank you very much, Dr. Jeyakumaran. Next, I think usually what we do is take a photograph of the webinar. Ma'am, is that correct?
Yes, yes, we can do a group photo in the panel room, please. Yes, please. You could turn on your videos, professors, doctors in the panel room if you can. Dr. Nagata, Dr. Kawamura, Dr. Manny, Prof. Oh, Prof. Tati is unable to open her camera. Yeah, Prof. Okay, so Dr. Nico, you could guide us, please.
Okay, I will take photo in 3, 2, 1, smile. Okay, maybe Dr. Nagata, would Dr. Nagata open the video? Okay. Okay.
Yes, Dr. Nagata is here.
Okay. Let us take the photo one more time. In 3, 2, 1, smile. Okay, thank you, Professor and doctors.
Thank you.
Thank you very much. Let me now introduce our eminent speaker, Dr. Ajithkumar, who is a consultant clinical oncologist at Cambridge University Hospitals, UK. His research interests include radiotherapy for pediatric brain cancers and optimization of combination radiotherapy with novel agents in pancreatic cancer. He is the editor-in-chief of Clinical Oncology, the official journal of Royal College of Radiologists. He is also the lead editor of several textbooks, such as Specialist Training in Oncology, Oxford Dex Reference of Oncology, and Oxford Case Histories in Oncology. He is also co-editor in Imaging in Clinical Oncology. And he is also the chair of European Society of Pediatric Oncology, Brain Tumor Radiotherapy and Germ Cell Tumor Groups. So I'm sure our listeners will have a wonderful experience today listening to Dr. Ajithkumar. Over to you, Dr. Ajithkumar.
Thank you very much. Thank you for your kind invitation to present and all your kind words. It's an honor to be here. So I'm going to share the screen. I need to find the screen first. Okay. Can you see it all right?
Yes.
Yes.
Okay, thank you very much. So I'm going to share some of the experience in SABR in pancreatic cancer because I came to Cambridge to take over the pancreatic radiotherapy side of thing and try to develop where we should be going. And I'm sharing some of my experience as well. So to start with, as you know, pancreatic cancer still remains a very, very poor prognosis. And if you look at the chart, the pancreatic cancer is at the bottom with a 5-year survival of less than 10%. And it's mainly because surgery is the only definitive treatment, and only less than 20% of people will be suitable for surgery. And this is how we manage pancreatic cancer in the Western world. It broadly classified into operable, borderline operable, locally advanced or metastatic disease. Operable patients go straight to surgery and adjuvant chemotherapy. We use 2 types of chemotherapy in Western countries. One of the trouble is still after surgery, around 40 to 60% of patients will have margin positive disease. We also use neoadjuvant treatment in borderline operable and locally advanced cancers to enhance the chances of surgery. Still, the outcome is poor. Like I said, only 15% people are resectable, and their median survival is just under 3 years. And whereas the locally advanced cancer, the median survival is just over a year, and majority of the people with the metastatic disease die within a year. Oh, it's going to be a bit tricky. I got a problem at the moment. My presentation is not the right one. Sorry, I need to switch to new. Can you see the slides now?
Same slides.
We still see the same previous.
Still
Has
the
it
same
changed
as
now?
before.
We are seeing the same slides. Probably you should get out of this one and then share.
So that's been changed now, isn't it?
Yes.
So I think next I'm talking about is what is the role of adjuvant radiotherapy, particularly SABR in pancreatic cancer. So if you look at adjuvant chemotherapy, this is mainly based on two trials, which is SPAC4 trial, which is published 3 years ago. And gemcitabine and capecitabine had a better prognosis than gemcitabine alone. So that became the standard of care. And a year later, the Prodigy 24, which published a comparison of gemcitabine versus modified FOLFIRINOX. And then modified FOLFIRINOX became the standard of care. But in our routine practice, what we do is in patients with a poor performance status or elderly, we still stick with the gemcitabine, capecitabine, whereas people in a good performance status after the surgery, we go for modified FOLFIRINOX. But when it comes to the adjuvant radiotherapy, there aren't huge data favoring radiotherapy. So the first trial of Europeans were the SPAC1, which was kind of a primitive way of giving radiation treatment, giving total 40 gray split course, and it did not show any improvement in survival. So after that trial, the Europeans completely abandoned the practice of giving adjuvant radiotherapy, which was in retrospect a mistake. And the American study, which looked at that, was the RTOG 9704 trial. But both this study has got chemoradiotherapy as one arm, but they were looking at the addition of gemcitabine. And they also had one trial, which is RTOG 0848, which was answering two questions, asked whether an adjuvant TK is beneficial or not. But the radiotherapy question is yet to be published. However, in America, when patients have a margin positive disease or node positive disease, their standard of care is to give adjuvant radiotherapy. This is a practice we don't follow in Europe. So what about the adjuvant SABR? So there are 3 studies. The first study is actually the one reported this year. In R0 resection, patients received gemcitabine or gemcitabine plus SABR. It's only a small study of 38 patients. All the patients received 25 gray in 5 fractions. And the median survival was actually not significantly different. And the median local regional failure survival also more or less the same in both groups. What about the close or margin positive disease? This is a single arm study of 76 patients treated with the 36 gray in 3 fractions. They only treated the areas of margin positivity, and the local regional failure at 2 years were significantly higher, and almost one out of 2 patients recurred. And majority of the recurrences were just outside the area they treated, but that would have been an area they must have used otherwise in a conventional radiotherapy field, because this study didn't make any attempt to include any elective nodal sites or anything like that. And the third study, which is not reported, but there will be results available in the clinical trials website, is the NCT 013575525. It is for close and positive margins. They again give 36 gray in 3 fractions, and they reported 2-year progression-free survival of 78%. So in fact, we really need a randomized study looking at what is the actual role of SABR in the adjuvant setting, because we can't see any clear benefit in R0 resection. Whether in RN resection it is beneficial. Then the other question comes is what sort of radiotherapy field we use. So these are all 2 studies, which most studies have more than 200 to 300 patients. After surgery, how the recurrences occur. So they outlined a superior mesenteric artery, which is blue, and celiac axis, which is yellow, and the recurrences based on postoperative treatment. So the one group is, I think the red group is they have no adjuvant treatment, green is gemcitabine, and the other color is gemcitabine with some radiation treatment. What they observed was there are recurrences usually occur within 2 centimeter margin from most proximal 1 centimeter of celiac axis and 3 centimeter of SMA. And the question still comes is the LFT node, should we irradiate or not? So there are 3 studies looking at that, but that is not clearly all interoperable situations. The first study is the one randomized between SABR with or without elective nodal radiation, which is all groups irrespective of whether there was operable, borderline, or locally advanced. They're all after surgery, they have been randomized to any of these. The 2-year local regional progression was actually in people who actually didn't receive elective nodal radiation treatment. However, there was no difference in the overall survival. The second study was for borderline and locally advanced after R0 resection. So 96% of this group had R0 resection. Still, there is 1/3 recurrences occurred in the local regional place. And then the third study, where the resectable patients were only 3, and it's a small study, and 92% had R0 resection. Once again, the one-year local failure is 50%. So there is a paper published this year suggesting that when you're considering a post-operative radiotherapy, it's worth treating elective node. The problem is the clinical target volume they are suggesting for treatment is actually quite broad. So we don't know whether it is truly going to be beneficial, and we really need to have a randomized study looking at this. So what are the neoadjuvant options in the operable setting? So there is always an attraction for neoadjuvant chemotherapy because it allows for better patient selection. So say, for example, the common neoadjuvant treatment is chemotherapy, and some of the patients can progress during chemotherapy and they can avoid surgery. Probably neoadjuvant chemotherapy ended up in a potentially higher chance of R0 resection, or they may get in an early treatment of metastasis, or it may be more effective in perioperatively. However, phase 3 study, 3 phase 2 studies failed to show any benefit with the chemotherapy. Then what about chemotherapy along with radiation treatment? So there are 2 studies reported recently. One is the Dutch Perioperative study. They used a hypofractionated treatment, 36 grain, 15 fractions. It wasn't truly SABR, but they used a technique very similar to SABR. And they found that the overall survival is better with the previous treatment, but it wasn't statistically significant. I can't see the. Whereas there was better R0 resections with the preoperative treatment. The other study was the European SPAC5 study in borderline group. They had a combination of neoadjuvant GemCap, FOLFIRINOX, or CRT, where there's only 16 patients received chemo-RT. And generally, patients who received neoadjuvant treatment had a better overall survival, but the exact role of radiotherapy is not clear. The currently planned pre-PANC2 studies looking at FOLFIRINOX versus gemcitabine plus the similar hypofractionated radiotherapy. So this is recruiting now. So there are a handful of preoperative SABR studies going on in different centers across America and Italy, but none of these studies are conclusive in terms of whether there is a true role for treatment neoadjuvant SABR in operable pancreatic cancer. So what about borderline operable and locally advanced? So we could use, in this situation, the treatment we are using is mainly looking at whether they are going to make the operability better. So if you look at the role of chemotherapy and chemo-RT, generally in terms of survival, there are 4 trials looking at chemo-RT with the gemcitabine. It's ECOG trial, which showed slightly better survival with the chemo-RT. SCALLOP2 trial, which wasn't answering the question of radiation. It was looking at which is the best agent to combine with the radiation treatment, either gemcitabine and capecitabine. And they found better overall survival with the capecitabine. And LAB07 trial, which is the one which is always quoted by medical oncologists to prove that there is no role for chemo-RT. But this is a study in the era of gemcitabine, which showed there is no difference in overall survival with the addition of chemo-RT. SCALLOP2 trial looked at 2 things, which is whether the dose escalation to 60 grain 30 fraction is better, or a radiation sensitizer like nelviravir makes any difference. This study did not show any benefit with increased dose or any benefit with the radiation sensitization. The ongoing study is the RTOG 1201 study looking at 2 different fractions, mainly escalating the dose. So However, if we look across all these studies, the locally advanced pancreatic cancer become operable only in less than 15% of cases. And what about SABR in these situations, whether it makes operability better? So if you look at the studies, the operability rate with the borderline tumor is 50 to 55%, which probably, this is a tricky situation because borderline operability is, even though we got definitions, which are 4 definitions, which are slightly varied, but it's entirely depending on the bravery and skills of the surgeon. And in locally advanced, they can get 20 to 24% operable. Once again, it depending on how brave your surgeon is and he's ready to open up and see whether he can operate it or not. In the larger series by Malone, the resection rate was around 51%, which has got both a borderline and locally advanced, and also resection was achieved in 96%. And the people who had a resected tumor has a much better overall survival compared with people who hasn't had surgery. And toxicity wise, the grade 3-4 intestinal toxicity was less than 10%. And it is less toxicity with the 5 fractions of SABR. So it is acceptable toxicity. However, I think this is again, people do SABR in completely different ways, using a dose between 25 gray to 50 gray. So there are a lot of things we don't know. So what next? So I think one of the main important aspects is the only way we can improve the survival is you had to enhance the R0 resection. So if you look at the SPEC4 data, this is one study reported the benefit of a gemcitabine versus gemcitabine capecitabine based on the margin positivity. In this trial, there was a very high incidence of margin positivity. It is as high as 60%. So if you look at these 2 graphs, that is belong to a margin positive patients are treated with gemcitabine versus gemcap. So whether you treat with the gemcitabine or gemcap, even though this study is reported, overall it's a better report. But in RN resection, there is absolutely no benefit of adding gemcap. And it only benefited the patients received, had an R0 resection. So it is very important in terms of either achieving an R0 resection or addressing an RN resection proactively. So how can we improve the cure rate in pancreatic cancer? As I mentioned, the R0 resection rate is 40 to 60%. So we need a more preoperative approach to improve the R0 resection, or we need to have an approach to improve the local control after RN resection. In addition, we need to make use of all the available radiotherapy techniques. And I know we have been using 50.4 gray auriculan for the last 70 years. We haven't made any difference. So it is the time we change the tactics. And then the other thing is there is a lot of novel agents coming on a day-to-day basis. The question is, can we exploit the synergy between novel agents and radiotherapy? So we all hear about from experimental studies, if you give a fractionation similar to stereotactic RT, it is pro-immunogenic. And if you give a standard conventional radiotherapy fractionation, it can be growth inhibitory, but it doesn't have pro-immunogenic effects. And in translational studies, there is enough data say that the radiotherapy, particularly the ablative doses of anything between 6 to 8 gray per fraction, can increase the tumor immunogenicity. It can enhance the immunogenic cell death and immune cell infiltration. The question is whether it is only applicable to a immunologically cold tumor or hot tumor, or we can convert the immunologically cold tumor into a hot tumor with a stereotactic ablative radiation treatment. And there are a lot of combinations you could use with the radiation treatment, exploiting synergy. The 2 particular compound which was interested to me is whether radiation can increases the tumor cell antigen release and optimal immune response, whether addition of immunotherapy will enhance the outcome. And the other thing is whether a DDR inhibitor can reduce the DNA repair and enhance the tumor kill. And there are a lot of studies looking at immunotherapy and radiotherapy in pancreatic cancer, but none of them are, most of them are recruiting and none of them are conclusive. And there isn't very many studies looking at the optimal combination of SABR with immunotherapy in the perioperative setting. And there is one study, which is the AstraZeneca funded study using durvalumab in borderline operable and locally advanced setting. They're not looking at anything in particular other than the endpoints of progression-free survival and median survival. So it's a mixed bag of things where its definite conclusion cannot be drawn because we really don't know what immunotherapy does with radiation treatments. And if you look at the preclinical studies with immunotherapy, radiotherapy combinations, all the radiotherapy schedules used are something like 1 fraction or 5 fraction maximum, because these are all cell line. And as we all know that it is notoriously difficult to translate an experimental data into a human being. And particularly if you wanted to give 15 grain 5 fractions in mouse, what does it mean in humans? So we need to have a method to study. We need to be using the same technology, same methodology when you're doing experimental studies as well as the human studies. And also the tumor models you use in experimental studies should closely match with the human tumor. So that's why we designed the so-called Portico platform, which is the preoperative stereotactic radiotherapy in combination with immunotherapy or DDR inhibitors as a window of opportunity feasibility studies. So this is a study funded by AstraZeneca with a collaboration of Cambridge Cancer Center and University of Cambridge. So our hypothesis is we think ablative radiotherapy can induce immune modulatory changes in the tumor microenvironment in pancreatic cancer. However, there are mechanisms, which is an induction of anti-tumor T-cell mediated response can be opposed by immunosuppressive mechanisms already present in the pancreatic cancer. And we were trying to evaluate the immune tumor microenvironment at baseline and following radiotherapy to see or find some signals where we could derive a logical combination to take it into clinical trial. So we were trying to characterize the baseline tumor immune milieu in operable pancreatic cancer, and we actually did a biopsy. We had an endoscopic biopsy, and we also take an intraoperative biopsy, and before tumor devascularization and after biopsy. This is to compare whether the T-cell population is different with the devascularized and vascularized tumor sample. That is called the Portico Trans study. Then the Portico SABR studies, we try to give radiotherapy before surgery in an operable patient to see how much changes it causes in the immune microenvironment. And then we could find the optimal combination of immunotherapy or DDRI to take it to the clinical trial. The unique features of this platform is, I think our surgeons are mainly worried about giving radiation treatment just before the surgery and how much it will add to the fibrosis already existing and the difficulties in surgery. So we thought we will give radiotherapy the week before surgery to mitigate any concerns regarding technical difficulties of surgery and avoid any possibility. So it got better surgical community acceptance. And it is a window of opportunity study. And we wanted a population where we haven't given any immunosuppressive treatment for this group of patients to see whether truly radiation can cause an immune modulation. And this is probably the first clinical study with a robust translational endpoints to evaluate preoperative RT. And the other thing is we treated the experimental animal with the same design as that of the clinical trial. So this is the overview of the study. So Portico Trans is trying to characterize immune milieu. Portico SABR is to characterize 5 fractions followed by surgery on day 8. Then in the lab, we are using all sorts of combinations, which is mostly come from the pipeline of AstraZeneca. So there are a lot of, I think what the model we chosen was KPC tumor cells. So if you look at the human pancreatic cancer, it is kind of devoid of T cells and full of tumor suppressive myeloid cells. So we kind of, so we wanted to capitulate the same situation, which is tumors poorly infiltrated with the lymphocyte, but dominated by myeloid cells. And we derived this particular cell line to use it. We give 5 treatments to the mice, and then we monitor the growth. Then we kind of combined a lot of combinations of drugs. Some of the results I can't show you, so I'm moving on faster. So what happened? So we are doing a lot of studies of various combinations. There are some interesting signals we could see with the combination of SABR. But we were supposed to start the Portico study in April 2020, which was suspended due to COVID. Then the surgery, theaters, everything closed. However, we got a national guideline to cut down the fractionation in pancreatic cancer. So I started treating patients using the same protocol with the 35 in 5 fractions. And I think so far we treated 74 patients in the UK. And the 4 patients were part of the Portico SABR trial, and 1 patient was in Graco trial, which I will come to that. I think it was an early experience for me. So some of the early patients, we had to reduce the dose to 30 in 5 fractions. But in the last 1.5 years or 1 year, we only give 35 in 5 fractions. We looked at what happened to first 40 patients we treated. So we had a referral from around 6 hospitals. The age group is 71.5, which is in keeping with pancreatic cancer. Almost equal proportion of male and female, equal proportion received induction chemotherapy. And I have treated all kinds of spectrums and sizes of tumors. And we used the LINAC using VMAT. We usually use a 2-arc. And 12 patients in this cohort had operable disease. 3 actually after the treatment, they were all treated during, these patients are treated during COVID pandemic. 3 declined surgery, 5 seemed unfit for surgery, and 4 were deferred, and 2 were operated. And on the one borderline patient who had a huge history of cardiac morbidity, so can't have any chemotherapy. So I just gave him gave him just radiation alone. And he became operable, he even don't have surgery. And if you look at the overall survival and progression-free survival, we could not find much difference in patients treated with radiotherapy alone versus radiotherapy plus chemotherapy. But it is a small sample, so it doesn't mean anything. But what we observed was the acute toxicity was bare minimum. So it was always grade 1, 2. Fatigue was a common side effect, but usually comes 1 week after completion of treatment. And there were no grade 3 toxicities. 1 patient, which is a patient with a borderline tumor treated with radiotherapy alone, he developed acute hyperglycemia after 2 fractions, but he continued treatment and completed. And our median overall survival was 14.2 months, which is more or less similar to the reported literature. And the main thing is the hospital visits of patients were reduced by 82%. And nowadays, I don't even see any patients face-to-face. Most of the consultations are virtual. I talk to them about radiation treatment. They come to the department to get the treatment. 2 weeks later, I will give them a call asking how they managed to do the treatment. So it's very convenient for patients, particularly if the median survival of people are like 15 to 16 months. There is no point in bringing them backwards and forwards into the hospital. So then it needs to be compared with the small trial, because there is a lot of things going on, particularly marketing-wise, otherwise, how much the MR LINAC is going to make the difference. So this is the small trial, which is the 30 patients. They treated 50 grade in 5 fractions. But if you look at the median overall survival, it is actually not different from our 40 patients, which they had 14.2 months. And they had no grade 3 toxicities. They have grade 1 and 2 toxicities the same. And 9 patients had surgery, and the patient had surgery at a better outcome, which we all know. So it kind of begs a question that, do we really need an MR LINAC to give 50 grade in 5 fractions? So I wanted to share a case study with you because we have enough experimental data showing there can be immune modulation. So this is the borderline operable patient. As you can see, it was involving most of the SMV and going towards the SMA. And I treated them with a 35 grade 5 fractions. And then when the pathology was discussed, with the radiologist, the pathologist said, oh, it's rather unusual, all the postoperative pancreas we see. There's a striking lymphocyte infiltration which is not seen in pancreatic cancer. So if you look at all these violet colored dots, they are all lymphocytes. It is a nucleus of lymphocyte. And if you look at the adenocarcinoma where the arrow is, all the cancer cells are being degenerated. So it is not around the ductal adenocarcinomas. It's actually causing the same sort of the purple color T cell lymphocytes across the whole specimen, including the normal pancreas they took out. So then I asked them that, can you characterize what sort of T lymphocyte it is? So they went back and said that it is a CD8 positive lymphocyte. So we think this is what we were trying to prove with our Portico study, that there are, SABR has the potential to increase the immune modulation and increases the CD8 positive T cells. Then after COVID is over, we just started recruiting for the Portico SABR study. So 4 patients so far received radiotherapy, 3 had surgery. The 4th one had a cardiac arrest due to arrhythmia at the operation theater, so she could not have the surgery. Then so I treated all sort of things. So generally, the tumor I treat is just the tumor which is seen on 3D CT scan and 4D CT scan with a 5 millimeter margin. I didn't make any attempt to include the lymph node region. The main reason for that is I just wanted to see the kind of immune modulatory changes happening in the tumor which is being irradiated, and whether there are different changes in the regional lymph nodes. So there are a number of Portico translational analysis is formed. It's mainly by AstraZeneca in Boston. So we are looking at the tumor microenvironment using a multiplex immunofluorescence platform, which is developed for AstraZeneca, which enables a quantitative spatial profiling of immune landscape. We are also doing multiple omics in both samples of Portico Trans and Portico SABR. This is mainly, we wanted to identify any signal which we can take it forward to combine with an immunotherapy or novel agent. So that's about the immunotherapy. So I wanted to talk about another agent which we are studying, but it started in America. We all know that radiation induces burst of superoxide, and superoxide dismutase is converted to hydrogen peroxide. But superoxide is highly toxic to normal cells, causing extreme toxicity in the normal cells. But when they are converted to hydrogen peroxide, the normal cells can easily manage them converting into oxygen and hydrogen and water. Whereas when it comes to the cancer cells, it's actually hydrogen peroxide is more toxic than superoxide. So the question is, can we alter it? So dismutase mimetics can actually fasten the conversion of superoxide to hydrogen peroxide. So there is a differential effect that there is normal cells will be saved or repaired more or damaged less, whereas there will be more killing of the cancer cells. Does it really happen? So this selective dismutase mimetics been in an experimental study, as you can see. The mice are treated with the total body irradiation and received different doses of dismutase reductase and a dose of 20 milligram per kilogram or above. And the survival was almost 80 to 90%. So it does actually reduce toxicity in mice. Then they also studied in experimental animals, is there a dose effect with this dismutase and the dose per fraction? As you can see with this particular agent, GC4419, the 10 grain 2 fractions and 80 grain 1 fractions and all the hypofractionated thing can result in a better biological response. So this has been taken into a phase 1-2 study, which is they're giving 50 grain 5 fractions as a phase 1 study looking at placebo. And then they're evaluating what happened. It's a total of 18 patients received placebo, and then the drug is received by another 24 patients. What they noticed is 1 year was there are similar SBRT toxicity, whether it's been treated with the placebo or the combination, and there was no early or late toxicities. So this has been. And also when it comes to overall survival and progression-free survival, they are much better with the combination of the dismutase reductase inhibitor, so mimetic, and the disease-free control, both local regional disease-free control and distant metastasis rates were also better. This led to the next trial, which is a randomized trial of Graco2 in borderline operable and inoperable disease, where patients will receive at least 6 cycles of modified FOLFIRINOX or gemcitabine doublet. Then they are randomized to 5 days of SABR, which is 50 grain 5 fractions on consecutive days with the GC4711 or with a placebo. This is, I think this is probably, it's one of the brave study where they didn't insist on using MR-Linac to give 50 grain 5 fractions. So this is the first patient's completed treatment in the UK. I treated her a few weeks ago. So she has got a disease which is infiltrating around the superior mesenteric artery. She's been treated with the 50 grain 5 fractions. The only side effect she had during the treatment, she had nausea, which is being treated with olanzapine. So that kind of essentially saying that, you know, you can, if you have the right expertise, you can actually give 50 grain 5 fractions using your Linac. You don't have an MR-Linac. You don't need an MR-Linac. So what are the, in terms of techniques I use always 4D CT scan. For the initial few patients, I evaluated how much it moves. It's seldom the pancreatic tumor moves more than 1 centimeter, and seldom I have to use abdominal compression. But accurate delineation is a nightmare. So you always need an element of intravenous. Without intravenous contrast, you can't see anything, as you may all know. And with the 4D CT scan, our initial data shows that the dose to the duodenum can be reduced by 25%, and effectively a 5 gray dose reduction if you use 4D planning rather than a 3D planning. And preparation, we asked for 2-hour fasting. We used double contrast. Initially, I started with oral contrast, but one of the problem with some of the pancreatic patients, so they have a slowing of the GI tract, and that means most of the time oral contrast is held up in the stomach. It seldom goes into the duodenum. So we don't know which is the optimal time it reaches the duodenum. So we kind of abandoned that practice. And also we take the deep expiratory breath hold scan in parenchymal phase. Only problem is the contrast enhancement vary, depends on the fibrosis and pancreatitis. And there is actually different ways. So in terms of contouring, I think the most challenge I come across is finding the best window setting. Then you have to look for the tumor in relation to blood vessels, and there is general belief is that if there is a tumor around the blood vessel, you will include the whole circumference in the target volume. And also you have to carefully look for any perineural invasion, which can be one of the causes for local regional recurrences. So as I mentioned, the window setting can be a nightmare because there is a difference in terms of the tumor and normal pancreas enhancement in pancreatic and portal vein phase, and also the attenuation value of pancreatic cancer, depending on whether it is an operable or borderline operable. So I usually use an individual window setting. Generally speaking, in a locally advanced, the window level of the tumor is around 90 to 100, or operable, it is 45 to 60. And I might end up with, oh, sorry, the other way around. And I may end up with a window level, which is extra 40 to 50 and try to do with it. How does it in? So this is the 2 pictures. So this is the window level, which is the abdominal window level. And if you outline the tumor, you know that, you know, it's always easy to see when you outline something. But if you just see the tumor, it is very difficult to know where the tumor is, where the pancreas is. So I kind of, in this patient, I used a window setting of 60 and 120, which actually makes my life much easier to identify it and go back. And this is another patient where I moved from the typical abdominal window setting to something individualized for this patient, which makes life easier in terms of outlining. And in operable disease, as I said, it can be tricky. So this is the standard window setting. And if you kind of changes, I think particularly in the anterior part, which bit is the normal pancreas and which bit is a tumor. But if you go to a slightly different setting, there is more contrast enhancement in the anterior part, so which is the normal pancreas enhancing. So Then it get almost nightmare when you have the 4D CT scan, because its quality is much lower. In lung cancer, people treat with the SABR, they use the same window setting as the lung. That doesn't always work with the pancreatic cancer. So you kind of play with the window setting a while to find out the best way where your eye cannot out to see where the tumor is. And in most instances, in my experience, it's kind of a confident blind drawing. Organs at risk, again, window setting is very important. See, one of these patients, so I don't know where the picture on the left is the standard abdominal window setting. So you can see the abdominal fat as well as the air. So in order to distinguish, I kind of increase the window width, which makes the abdominal fat bit grayer, and I can distinguish air better. So you could actually play with the window setting for organs at risk. And you had to use all images, both axial, sagittal, and coronal, to identify the organs. And thing is that none of the patients have a similarity in terms of outline, either in the tumor or in the organs at risk. So how I do it is, I don't straight go into outlining the tumor. I start with the third part of duodenum, which is easy to identify. Then I trace the remaining. Then I start looking at the transverse colon. Then I look at the small colon. I think what does happen is, in between, I am scrolling up and down. I get a sneak peek of the tumor, and more and more I look, it gets more and more clear for me. That's why I start with the organs at risk. And GT, I play with the window settings. Then it's a usual thing what you do. Verification is important. We tried various things. We tried oral contrast and water contrast. It didn't make anything better. I even tried fiducial markers. Then fiducial markers end up in all kinds of artifacts. So I kind of stopped that doing it. Now, recently I was told by one of my American colleagues, when you're putting fiducial marker for verification, don't put anything more than one. So one is sufficient. If it is more than one, it causes a lot of artifact. Then the other bit is, 3D versus 4D cone beam CT we used. I think 4D cone beam CT in our experience has got a very poor quality, so we stick with 3D cone beam CT. So the question is, we are using chemotherapy for pancreatic cancer for nearly 60 years. We don't have a specific chemotherapy pancreatic cancer. We are actually repurposing existing chemotherapy to pancreatic cancer to find something. And we are using radiotherapy for the last 70 years. I think the first report of radiotherapy use in PubMed was somewhere in 1953. So the question is, can we change our conventional thinking? We becoming heavily believing in the chemotherapy. Can we change the tactics? Because we know that SABR can improve local control and symptoms. So in any patient, particularly locally advanced patients, there is no harm in giving SABR as an upfront. And can it be used as a screening tool for future response? So this is mainly based on the patient I have explained, because the patient I have seen after SABR, there are such intense reaction. So the question is, if you give SABR upfront, after surgery, you could have a tumor with immune modulation. I don't know what proportion it might be, but that group of people will be better served with immunotherapy rather than chemotherapy, because chemotherapy has a risk of destroying all the activated T cells. But there may be a proportion, or most of them, I don't know, when I have no immune modulation. That's the situation we need to try adjuvant chemotherapy. Can we use SABR as a screening tool inoperable? So you give SABR, you get a biopsy. If there is immune modulation, can we continue with an immunotherapy-based palliative treatment? Because whichever way you treat it, the median, we haven't improved the median survival beyond 15 to 17 months. And if there is immune modulation, can we change it? So I don't know. This is something which needs discussion with our medical oncology community. It will be a paradigm shift in the way we think, but we need to realize that we use chemotherapy and radiation in various permutation combinations, and we are yet to make a huge impact in pancreatic cancer. Thank you.
Thank you very much, Dr. Ajithkumar. It was a very interesting talk, and it leaves us to wonder a lot of things about pancreatic cancer and how we are going to manage these cancers. Today, we have 3 panelists in our panel. The first panelist is Dr. Makoto Shinto. He's working at QST Hospital, that is National Institute of Quantum and Radiological Sciences and Technology in Chiba, Japan. He's specializing in carbon ion radiotherapy. And he has done his education at Kyushu University School of Medicine, Fukuoka, Japan. The second panelist is Dr. Jaskaran Singh Sethi. He is a senior consultant and chief of GI, hepatopancreatic biliary and pancreatic radiation oncology at Rajiv Gandhi Cancer Institute and Research Center, India. He has special interest in SABR, SRS, in management of motion during radiotherapy. Our third panelist is Dr. Niroshan Atulgama. He is a surgical oncologist attached to Sri Lanka Ministry of Health. His special interests are hepatopancreatic biliary cancers. He works at organ transplant and hepatopancreatic biliary unit at Addenbrooke's Hospital, Cambridge, and Royal Free Hospital, London, as a senior clinical fellow. So I looked at our Q&A panel. I haven't seen any questions written, but first I would like to have some comments from our three panelists. Let's first hear from our surgical colleague, because that's where we, at the moment, cure patients with pancreatic cancer. So Niroshan,
yes,
would you like to comment about this talk and how you think about SABR as a future for pancreatic cancer management?
Yeah, Dr. Ajithkumar, that was a fascinating talk, actually. I mean, you have done a lot of hard work. Anyway, I mean, I think I like to take a different stance when you look at, in general, about radiotherapy in pancreatic cancer. We know it's a very difficult cancer and it's systemic from the very outset. And so what we know is that, some form of perioperative chemotherapy would provide you some overall benefit, either in the neoadjuvant or adjuvant setting. And if you use it in the neoadjuvant setting, of course, there is a little bit additional edge. And you know that, if you go for adjuvant treatment, 25% of patients would not proceed with adjuvant treatment because of the debility after surgery. So, but what we doesn't know is actually whether you're adding radiotherapy to neoadjuvant treatment, whether it gives an additional survival benefit. As Dr. Ajithkumar said, there were many trials. Even if you look at Alliance trial, specifically they were looking at stereotactic body radiation against neoadjuvant chemotherapy. They didn't show a survival benefit. Somebody can bring up pre-panc trial, as Dr. Ajithkumar said, but then again they were using gemcitabine plus radiotherapy. Actually, the trick is done by radiotherapy or actually the chemotherapy part. And also some says that infection rates. Well, if you look at only prospective chemotherapy trials in the neoadjuvant setting, they also give you good survival rates, and also they will give you like 90% R0 resection rates. So we are not very sure actually radiotherapy does any better in terms of neoadjuvant treatment. My second point is actually, unlike other cancers, pancreatic cancer doesn't downstage with neoadjuvant treatment. It only shows 4% of complete clinical response. 80% of the time it will be stable disease. So you will be doing the same surgery even after neoadjuvant treatment. And nowadays surgeons are becoming better and better. So you can get R0 resections with vascular resections and reconstructions. People are now getting better with less morbidity and mortality. Third point is, as I said, we all know we need something systemic, more effective systemic treatment. And of course, we need to look forward for target therapy. Now, in that sense, I think we have to look at the tumor genetic markers. I'm doubting that, and there is evidence that if you give radiation, the genetic signatures might change. So you will not actually catch that real tumor biology. So because of all these factors, I'm a little bit hesitant still to use radiotherapy. But of course, you know, as Dr. Ajithkumar said, you know, immune modulation with SABR, I think things might change in the future. Let's see.
Yeah, Ajit, comments about it?
I think thank you for. I think your hesitation is shared by radiation the surgical oncologists across the world. I won't blame you for that. The only person I come across who is actually actually say that, you know, said to me probably 3 weeks ago when I met him as well. He said that you know, if you give some radiation to that bit, I will be more comfortable resecting because I don't find any problems. I don't know whether you know him. He's somebody called Mokengi Malafa. He's a surgical oncologist in Moffitt Cancer Center, because he has got extensive experience of giving SABR and treating. Because I think the reason I had to put the portico is because our surgeons were really worried. Not surgeons, one or two. There are surgeons. I got a surgeon who actually operated 1.5 years after radiation treatment. He said it is like cutting through the brick. But when he cut it through the brick, but he did it because he was also a transplant surgeon, and he does the triple transplants and things like that. For him, it will be an easy job. Then that patient, he had got an osteoid section with no tumors inside. So so it entirely say, I think pancreatic cancer is a surgeon's field. I think the whole thing about, there are times I have asked one surgeon or two surgeons, three surgeons, but probably the third surgeon operates this, the first two surgeons don't operate. And this is the problem. It's not something to do with, that is, I think, partially to do with the imaging techniques we got. Our imagings are not good enough to predict the operability. Our imaging is, you know, in the world of, you know, radiological world of, you know, white, dark, you know, black and white, everything in pancreatic cancer is a gray zone. That's a problem. So I think you know, like this is what I think. There are, you know, you are not alone in terms of sharing your concerns about radiotherapy. But what I am saying is very simple. We tried these games for the last 7 decades. You need to change the game.
Exactly, Adi. We are not doing well with our pancreatic cancer. So we need to do something more to improve our outcomes. My next, I would like to ask Dr. Makoto Shinto to give your comments about it. Especially, I know that you are at QST where you use heavy ion carbon therapy, and especially your experience with carbon ion therapy for pancreatic. And have you used any hyperfractionated regimes for pancreatic cancer in terms of adjuvant or neoadjuvant setting?
Yeah, before so we performed the preoperative carbon ion radiotherapy, but now so we do not perform. This is because of the government insurance. Yeah, so now so our main target is the locally advanced pancreatic cancer with definitive carbon ion radiotherapy. So, but so in the case of the borderline resectable or the R1 rejection cases, so chemotherapy alone is insufficient. So I believe that the preoperative radiation is needed. So I want to question about the radiation field. So according to the data you showed about the elective nodal irradiation. So in the case with elective nodal irradiation, the incidence of local recurrence was a little bit low, but there was no significance between with or without elective nodal irradiation. So what is your opinion?
To be honest, I think at the moment, the thing is that if you are using SABR, what people used to do is they give 40 grain 5 fractions to the tumor bed where the margin positive and 25 grain 5 fractions to the elective nodal region. That's what they are recommending, and that's the new recommendations. To be honest, this is an area nobody knows, because it's not just the elective nodes it goes to. Then the other question, if we are not addressing the question of the perineural infiltration, how long this goes along this splanchnic plexus, because we have seen enough patients presenting with intense pain due to the disease going along this splanchnic plexus. So I don't have an answer to that, I'm afraid, because at the data, at the moment, probably for, if in an adjuvant setting, if you had a good dissection and you are treating it for R0 RM disease, I don't know, I suspect whether there would be a value in giving an elective nodal radiation, because we can use elective nodal radiation as a means to cover for inadequacies of nodal dissection, but one has done a good nodal dissection. I'm not quite sure whether it is going to add more. But again, studying these kind of things are going to be very, very tricky.
Yeah, thank you. So I think the most local recurrence after surgery or after SBR SABR, so they're around the common hepatic artery or around the SMA. So the incidence of local recurrence is very high. So I think so retroperitoneal or along the neuroplexus. So we should include that area. So this is my opinion.
I think one of the things I do now is if I kind of see, if they see the disease is involving SMA and SMV, I actually involve the whole, SMV, I take it up to the origin into the descending aorta, make it into that field. Because I don't know when it is, how much perineural spread going along. So our practice is to take the entire circumference of the blood vessels up to the, if something is an artery coming from aorta, I will go up to the aorta to treat it.
Thank you. You are muted.
Yeah, you're muted. Sorry.
Niroshan?
Yeah.
What do you comment about these recurrences around the vessels? Is it because the surgeons are more careful with the vessels and your dissection is slightly, conservative around those areas?
Yeah, I mean, so if you kind of, if you're a proper HPB surgeon, then of course you would actually skeletonize the whole vessels and you'll take a proper lymph node retrieval. You do a proper lymph node retrieval, but if you're not really trained in that, then of course, you will leave bits and pieces. And most of the time, the problem is between the tumor and the vessel margin, so interface. So, I mean, nowadays it's traditionally, we would actually skeletonize the artery up to the adventitia. And then of course, as I said earlier, nowadays, even doing arterial resections is not becoming a bigger problem for surgeons. So they are becoming better and better.
Thank you. Dr. Jaskaran, I think you would have treated so many pancreatic cancers in India. And especially with regard to the motion during radiotherapy, you would have done some studies around that. Would you like to comment about Ajit's talk and your experience with SABR in pancreatic cancer?
Dr. Ajit, first of all, a very nice talk, very good work being done on immunomodulation, which I think is the way forward for changing the game, as you're saying, because in our institute, like SABR, because the surgeons, again, like Dr. Niroshan, is a little apprehensive about radiation in operable patients. But yes, we do definitely treat borderline operable, and we also treat in definitive settings in unresectable patients. I think that the whole concept of immunomodulation is something that would come up strongly, and we're seeing it in other tumors also. And maybe it is the time to rethink our practices. And I would really like Dr. Ajit to share a few slides with me. I would like to present it on our tumor board regarding this Portico study to convince my colleagues that, yes, there are patients who might benefit from this. And we are missing that lot here in India.
Yeah, I'm happy to share the slides. If you can send me an email or share an email account.
We've been treating patients with motion management, but at times, like Dr. Ajit said, that we hardly see a lot of patients having more than 1 centimeter movement in pancreas. So at times we also treat with ITV generation, and it is much easier to treat in that rather than 4D CTs and end expiration breath hold techniques. Regarding fiducials, I just wanted to ask Dr. Ajit, so how many fiducials are you placing in your
So
operation?
I started with the 3 fiducials, but the 3 fiducials, when you go and take a cone beam CT, it created all kind of a flash effect, and they can't match the PTV with anything. So I think the ideally, if you are using fiducials for verification, you don't need more than one, more than in a good position.
Where do you insert the fiducial marker? Into the tumor or around the tumor? Where?
I think when we did the 3, we used it in the 3 different edges of the tumor. So
into the tumor?
No, we used it in 3 borders of the tumor. We used it anteriorly, posteriorly, and laterally.
I see.
But if you are
Because
using
I
one
kind of
marker, maybe you should put it in the middle, isn't it?
Yeah. I don't know. I think in order for the cone beam CT people to radiographers to see, we only need to put 1, because we are worried about where the tumor is. In that situation, it should be ideally in the middle of the tumor.
Yeah. So any other questions from the panelists?
Can I ask one question from Dr. Ajithkumar? What about using stents? Now, most of these patients will have stents if you have jaundice. And if you use kind of self-expandable metal stents, then will it affect your planning, radiation?
Not the usual stents we use, no. Also, I think you must have seen some of the pictures. You can also see the stent. Particularly the one before, I think 2 patients in the Graco patient had a stent, and the one patient, 2 patients who went for surgery after 5 fractions, they had stent as well. I think one of the feedback from the early report from surgeons came after the surgery, 5 fractions. They said is that the pancreas appears to be a bit more swollen than they usually see, which is exactly what I expect, because when we give radiation treatment, it should be swollen. The question is, I wanted to know whether this swelling is useless swelling, or is it a proper swelling with the T lymphocytes? That's what I am after.
I have a question for Dr. Mukoto. Dr. Mukoto, you've been treating on carbon ions. What are your doses there?
55.2 gray in 12 fractions. So it is converted to about 70 gray in terms of conventional photon radiotherapy, I think. Mm-hmm.
And Dr. Ajit, how was your experience of treating at 50 gray 5 fractions without an MR-Linac?
I only treated 1 patient. She's fine.
Okay.
Because in UK, it's like we have a lot of restrictions. I'm not allowed to go above 30, 35 in 5. So the only patient I got a chance to treat with the 50 in 5 is the Graco2 patients. That is the first UK patients. It's actually brilliant. Not even 55. That is consecutive days 55 with either placebo or this dismutase reductors. And the only side effect she had was sickness. So, and we got, well, I have treated privately, so I don't want to talk about private treatment, but there is an experience of treating privately using a MR-Linac. I think they have been currently treated until 75 patients with a MR-Linac. And in terms of toxicity, it's most the same. And in terms of, one of the problems with MR-Linac is you can only treat 8 patients or something like that. But I didn't think MR-Linac actually has given any better results. So they are planning a study of using chemotherapy alone versus chemotherapy plus 50.5 using MR-Linac. That's a new study is being designed now. But I think my view is, we all, all the organs has got, different tolerances, except 1 or 2 organs, they usually move around. unless there is a previous history of, except, duodenum second part, it will stay there. If we keep the duodenum second part dose proper, all of the structures, my view is that they are actually moving around. And if you get it planning correctly, I don't think you're going to hit a lot of toxicities. And also, most of the time, if you're worried about the long-term toxicities, nobody lives beyond 15 to 17 months. If they live beyond 2 years, there is a 10% or 8% risk of toxicity. The question is, we have to balance for the certainty of dying if you don't treat versus the probability of getting a toxicity. So many people, I discuss delay toxicity, then their first response is, well, that is only if I am around, isn't it? So I think radiation oncology, we do worry a lot about late toxicities. We don't take into consideration of what is the median survival of these patients. Do they have, the median time to develop a gastrointestinal toxicity is 18 months to 24 months. And majority of the people don't have that time. So they don't live long enough. So I don't actually worry too much about the toxicities.
And so what about
toxicity
to the surgeon? What was the surgeon's feedback at higher doses?
I think I have a quite quite diplomatic way of dealing with the surgeons, because I think one of the prognostic factor in pancreatic cancer is surgeons. We never studied that. Because some of the surgeons are excellent, some of the surgeons are quite risk averse. So I have, I got 6 surgeons I work with, and I kind of deal with them exactly the way their personalities to get my study done. That's why I do it. Some surgeons are worried. Some surgeons are really worried about the late effects. Yes. But you always find somebody to do that. We got a couple of surgeons who actually do that. Because, once you delay surgery at least 5 to 6 weeks after radiation treatment, significant fibrosis sets in, make the tumor bed look like a rock. So I probably think the way I kind of walked around the surgeon is, even during COVID, I gave them a time that you need to operate within 4 weeks somehow. That's how I manage it. I think people are worried. I think in the UK, the other thing is that we always look at the surgeons morbidity and mortality things. So nobody wanted to be in the top of severe toxicity. So that's why everybody's slightly worried.
Good answer, Ajit. Dr. Vimuktini, have you got any written questions coming up, or would you like to ask any questions from Ajit?
So we haven't received any questions from the audience so far.
Okay. Do you have any comments?
I found Dr. Ajithkumar's talk very interesting, and I also agree with him that SABR and is like the way towards the future. Like at least something should change in the way that we manage pancreatic cancer. The survival rates are very dismal at present. Even the ones that are borderline operable or locally advanced have very poor survival rates. So we definitely need to change the game, and enjoyed the talk very much.
Thank you.
Thank you.
Any other questions from the
panelists?
Yeah.
Sir, I have another question for Dr. Ajithkumar, just for the residents who might be attending the webinar. What are your registrations, like your planning CT? You register with what other imaging at the time of delineation? So
the planning CT, I will use the 4D CT as well as an MRI scan. But the problem is it's very tricky, because even we use deformable co-registration, getting it right is difficult. So if you wanted to get it right, what you need to do is you outline the organs you think is important, and ask the physicist to match with the organs you outlined. Say, for example, if you outline a blood vessel or something which you are interested in the MRI scan, outline that, and in the CT scan outline that, then they might be able to do a better deformable co-registration. I mean, 4D registration is easy, it doesn't cost because they are done in the same time. But if you want any other things like PET scan or MRI scan. I use PET scan, I use MRI scan because when I use MRI LINAC, I use the PET scan and MRI scan and the CT scan, everything. But I think the trick is you need to get the deformable registration right. One way of getting is create a region of interest before you ask the physicist to fuse it.
And sir, do you follow any stomach protocol like during your simulation?
It's we ask everyone to have a 2-hour fasting, and when they come, that we will give 150 ml of water.
So this 150 ml you're giving just before acquiring the scan, I suppose.
Yeah, just before acquiring the scan and just
then
before
the
every treatment. Every
yeah,
treatment, yeah.
Yeah.
Dr. Shinato, you are using carbon ion radiotherapy for a lot of cancers. At the moment, in Chiba, what tumors do you treat with SABR?
Sorry, we don't use the SABR.
You don't, as carbon ion? No.
Yeah, exactly. So carbon ion therapy is like a stereotactic. Yeah. So we use only 12 fraction. So fractionation is a little bit different.
Different, right.
Dr. Shinato, the toxicities with carbon radiotherapy, is it different compared to SABR?
Yeah, I don't know in detail, but so the grade 3 gastrointestinal toxicity is less than 5%. This is the results of carbon ion therapy.
Thank you, Dr. Shinato.
Welcome.
So it looks like that we have not got any written questions. And if we don't have any more questions from our panelists, we can conclude because we are about to just 5 minutes to our time. So I would like to thank Dr. Ajithkumar for excellent talk. It opened our eyes to different areas, especially the immunomodulation. So that's some area that we can work on it. And the 3 excellent panelists for your contribution of this webinar. And I would also like to thank the Indonesian Society for organizing this webinar. They have been wonderful organizing these webinars all these years. And I would also like to express our sympathies on your recent tragedy, the recent earthquake at Indonesia. And I would also like to thank Dr. Vimuktini Piris, my colleague, who was the live buyer behind organizing this webinar, and all the FARO members for joining and enjoying this webinar. Thank you very much.
Thank you.
Thank you.
Nice to see you all.
Thank you, sir.
Thank you very much.
Thank you very much.